Yeah, let's start, Roland. So others maybe just remind your colleagues to join. They will join us as we proceed.
Yes, so thank you so much, Dr. David, for this opportunity for me to share this case. I hope it's going to be another session for us to learn. And this case, I cracked it at one of regional referral hospitals here in Dar es Salaam. And he was a 56 years male with difficulties in breathing for 2 months.
Okay.
So we can start from here.
Yeah. So difficulty in breathing. I'll try to be quick here because I'm not sure how long the case will be. And difficulty in breathing is one of those complaints that I take to be very broad. So difficulty in breathing. Another one is fever. And so that's for those which are a little bit more specific. But another one is if someone tells you I have easy fatigability, then again very broad. So for difficulty in breathing, I think I've discussed it here before. The way I approach difficulty in breathing is so I start with organ systems, and by organ systems I mean I'll consider pulmonary causes of difficulty in breathing, cardiovascular causes of difficulty in breathing, neurological, psychogenic, endocrine or metabolic causes. So all these are possibilities. So you've heard us saying a number of times that most of the time you hear about difficulty in breathing, many times it localizes to the cardiorespiratory system. It's either in the respiratory system or the cardiovascular system, and so the rest will fall in the other categories. So that will be the first layer. And when I talk about the respiratory system, I think about a number of diseases. So just to mention randomly, a pneumonia can cause difficulty in breathing, asthma can cause difficulty in breathing, COPD, interstitial lung disease, uh, and many other causes. So cardiovascular system, heart failure with all its causes, and then examples of neurological causes, Guillain-Barré syndrome, amyotrophic lateral sclerosis, and many other neurological conditions that you can think about. Neurogenic, a good example is panic attacks. Someone will have difficulty in breathing. Endocrine or metabolic, diabetic ketoacidosis, for example, and ketoacidosis in general will cause difficulty in breathing. We talk of Kussmaul breathing. Hyperthyroidism can cause difficulty in breathing. So the list is endless. So that's the way I start. I think about these major organ systems, and in a clinical unknown like this, because we'll have a history, I will listen very attentively to hear some supporting symptoms, associated symptoms, or the like, which will help me localize to a particular organ system. And then once I do that, I go to the next layer, which is I use the anatomical approach. So, for example, if I determine that this difficulty in breathing is most likely coming out of the respiratory system, then I think anatomically that the respiratory system has airways, and therefore I think about asthma, COPD, and other airway diseases. It has the parenchyma, the alveoli, so you talk of pneumonia, diffuse alveolar hemorrhage, uh, and other things that can come out of that place. The interstitium, so interstitial lung disease, the occupational lung diseases will be more of an interstitial picture. And then you have the pleura. So someone who has pleural effusion of any sort uh, will will present with difficulty in breathing. So that is the anatomical approach. And as an example, when I take that to the cardiovascular system, again, I can think about the blood vessels. I can think about so the blood vessels is an example when you have acute coronary syndromes or chronic coronary syndrome. Uh, and then the pericardium. So you talk of pericardial effusion, constrictive pericarditis, tamponade, and so another one is it can be an electrical issue. So you talk of arrhythmias, atrial fibrillation, or a conduction issue, a conduction or electrical issue in general. So when you have tachyarrhythmias or blood arrhythmias, all these will present with can present with difficulty in breathing. So that is the way I approach it. So what I'll be looking for is when you are presenting when you're presenting this HPI, I will listen in order to see if there are some symptoms that are leading me to a particular organ system. But then the challenge with that is the respiratory system and cardiovascular system, for example, share a lot of symptoms. So, for example, if you are told someone has difficulty in breathing and cough, cough itself does not localize that difficulty in breathing to the respiratory system. It could be coming out of the cardiovascular system. The respiratory system is an innocent bystander, and then you have difficulty in breathing associated with cough. So let's proceed, Roland.
Thank you so much, David. It's always such a wonderful opportunity to learn how you process stuff. Your schema is amazing. So this patient, the difficulty in breathing was of gradual onset. It was progressive. Initially, it was aggravated by exertion and relieved by rest. He could walk approximately 500 meters to catch a bus, then walk through his workspace. And over the last 10 days, the difficulty in breathing is now occurring even at rest. This difficulty in breathing was preceded with cough, which has been there for 4 years, and the cough had always been dry. It was initially on and off with no periodicity. That means it can happen anytime. It could persist for weeks and be slightly improved with over-the-counter medication. The patient described he would be given some tablets and some inhaler. Then currently now, over the last 10 days, it has been persistent, this cough. It is present throughout all the time, and it's no longer relieved by the medications which the patient had abused severally over the counter. And the cough was so alarming and relentless and concerning even to the family members due to the intensity. However, there was no history of wheezing, chest pain, coughing blood, fever, night sweat, or weight loss to this patient, and had awareness of heartbeat being reported on exertion. But currently, this awareness of heartbeats, they even occur at rest, with several interruptions for midnight for air hunger. And for him to catch a sleep, it could require up to 4 pillows. But there was no lower limb swelling, no syncope, and the rest of a review of other system was normal. So you can continue from here, Dr. David, and just to give you liberty. The case is not that much long, but it's the investigation part of which later you are going to recognize that most are going to turn normal. So take your time to educate us. We may learn a lot of stuff from you. So you are welcome, Chief, again.
Thank you. Can you project the slide on the introduction? I think this was a 56 years old male who presented with difficulty in breathing for 2 months. Yeah, so project the first slide of the HPI. So what we learn here is just from the time course, we start throwing out some differentials. So because if someone presents with difficulty in breathing, that is of very sudden onset, like someone was well and then all of a sudden they have this difficulty in breathing and maybe desaturating, then there are differentials that we should prioritize, like a pulmonary embolism, acute coronary syndromes. So the lethal 6 or 12 if you extend them. So pulmonary embolism, acute coronary syndromes, life-threatening arrhythmias, aortic dissection, uh, tension pneumothorax, and pathologies of that kind. But what we learn is that this patient has a 2 month history of difficulty in breathing, which has been progressive over time. And so we learned that from here that initially aggravated by exertion, but then as of current, the patient has difficulty in breathing even at rest. So we're in the territory of chronic difficulty in breathing rather than something acute. So although the list of differentials for difficulty in breathing is very broad, but we are already starting to shed some load. Let's see the next slide. Yeah, so cough, what I was talking about initially, that difficulty in breathing, you hear cough, a reflex is to think that this comes out of the respiratory system. But then there is a caveat here, because if you think about someone with heart failure, for example, they could present with cough. And so this cough does not help us very much unless we learn some things, especially now you hear that the cough is dry. So because if someone is presenting with a productive cough, sputum, and this sputum has some characteristics, you could think, okay, the airways are probably irritated, but then this patient has a dry cough. And yeah, so this cough was initially on and off, but then the cough has lately become uh, very persistent, and it's concerning to the patient and the family. Let's see the next slide. Yeah, so absence of wheezing. So commonly when we talk of airway disease, like asthma or COPD, these are commonly associated with associated with wheezing because of uh, bronchoconstriction, and then the ongoing inflammation that is taking place, a lot of mucus being produced, so that leads to further airway narrowing. You end up with wheezing. So but absence of wheezing does not completely rule out airway disease. The patient has no chest pain, so I talked about some differentials of difficulty in breathing and cough, which could be associated with chest pain, like coronary artery disease. But again, we do not know the medical history of this patient, whether they have diabetes or other conditions that could lead to neuropathies, and therefore making them uh, not able to perceive pain. So absence of chest pain will not throw out differentials like coronary artery disease, especially considering that this patient initially had difficulty in breathing on exertion. It was relieved by rest. That's an angina equivalent. But then we look at the risk factor profile of the patient and see if this fits the description. Although, yes, we commonly do not expect coronary artery disease to present with cough, unless now the coronary artery disease has led to heart failure leading to cough as a part of the complications. So the patient has no fevers, night sweats, or weight loss. Of course, when someone presents with difficulty in breathing and cough of this much duration, infections are important to be considered, tuberculosis being one of them, especially in our setting. And therefore, it's very important to rule out infection. But then, at least for now, we do not hear anything that is concerning for an infection. And tuberculosis is not the only infection. Of course, there are endemic mycosis, there are viral infections, parasitic infections, which can also involve the respiratory system and lead to this kind of presentation. But we do not see features that are in keeping with infection or inflammation in general. That is an infection, autoimmune disease, or malignancy. But just the absence of fevers, night sweats, or weight loss itself does not completely rule out these pathologies. Let's see the next slide. Yeah, so this next slide here complicates things because we pick that the patient has orthopnea, and I'm talking of orthopnea, and this is uh, um, uh, I'm making an assumption here, because if this patient is having needs to pile up pillows, that means they have difficulty in breathing when they lie flat, and therefore you consider that to be orthopnea. And the patient is also having paroxysmal nocturnal dyspnea, the air hunger at night. So these are symptoms that we commonly hear in patients with heart failure, and therefore I will also entertain this possibility that heart failure could be a possibility and try to look for the possibilities. Another thing is the patient presents with awareness of heartbeat. So commonly, of course, someone who has difficulty in breathing, for example, and they are desaturating, we cannot determine that at this point until we hear the oxygen saturation and other examination findings. But if someone is desaturating, that will activate the sympathetic nervous system, because this is so the body is sensing that I'm dying, it has to fight, and therefore awareness of heartbeat can come in someone who is having a purely respiratory pathology because of sympathetic nervous system activation. But the awareness of heartbeat, Venn diagrammed with the paroxysmal nocturnal dyspnea, PND, where I think we have to consider that some cardiac pathologies could be at play in this patient. So, do we have any other slide about the HPI? Okay, so the rest of the systems are remarkable. I think uh, the progress I've made so far is just to rule out causes of difficulty in breathing which are acute, which are of acute onset, or they are short-lived, like a pulmonary embolism, for example. And I'm talking about acute pulmonary embolism because there is someone could have chronic thromboembolic pulmonary hypertension, or CTEPH in short. In a patient like this, you cannot rule it out. So I think what I've done so far is just to rule out the acute causes of difficulty in breathing. But with regards to the chronic causes, I think we still have a lot. Although I think to a large extent I'm localizing this difficulty in breathing to the respiratory and the cardiovascular systems. I'm not very confident at this point to just say because I had PND and orthopnea that this is purely coming out of the cardiovascular system. So I think it's still I'm playing with that which is statistically true. More than 90% of difficulty in breathing, you localize that to the respiratory or cardiovascular system. So I still have those two systems. So in the other components of history, I'm interested to know the medical history of this patient, the occupational history, whether this patient has been working in mines, in textile industries, whether this patient is a smoker, whether they have diabetes, and other details which will help me make some progress in a way. So let's proceed, Roland.
Yes, thank you so much, David. So the past medical history of this patient had two admissions for identical respiratory complaints. The first admission was in 2022, and the last one was in 2024 before he disappeared. Then at both those two admissions, he was managed as a pneumonia patient in a peripheral hospital. And during the time of management, he said that he was given ceftriaxone, but also he described it as power safe. So I just knew this is ceftriaxone. And on discharge, he was kept on amoxicillin clavulanate. When he used those medications, he had a slight remission of symptoms followed by weak relapse. And he was diagnosed with rheumatoid arthritis in 2022 due to the presentation of bilateral joint pains and swelling in hands, wrists, together with the feet. And since 2022, he was kept on prednisolone and piroxicam till present time. And also he had multiple visits as an outpatient, which they are monthly, due to management of peptic ulcers disease, rheumatoid arthritis, and still they kept on prescribing him amoxiclav as a pneumonia patient, and had an exploratory surgery in 1999 following a gunshot wound. But however, there is no history of blood transfusion, non-drug or food allergies, and presence of other chronic illnesses such as hypertension, diabetes mellitus, tuberculosis, sickle cell disease was not there to this patient. And on family history, all of the siblings were healthy and there was no any inheritable disease identified. And on social history to this patient is a divorced patient who lives with his son and daughter, had no TB contact, and the house happens to be well ventilated. However, he has a history of smoking for 37 years, and on daily basis he would consume one pack of cigarettes, and stopped in 2022 after medical advice, and since he was told that he had pneumonia, so he had to stop. But there was no history of any other smokable agents such as e-cigarette, marijuana, and vapors. He was also had history of taking alcohol, and it was 3 times weekly, with an approximation of 22 units per week. But he stopped 20 years ago, and his history of alcohol, he just consumed alcohol for 6 only years. And his occupation, as you were emphasized, David, he worked as a lab tech for 1 year. That was in 1990. Then um, he worked then as a policeman for the next 10 years. And the incident which I just spoke about on past medical history, especially on surgical part, was the reason that he stopped being a policeman after having a gunshot wound. Then from there, he shifted his focus into being an entrepreneur, and he has a construction hardware. But however, he doesn't use mask when handling cement, gypsum, wall put, or all other agents related to that. So this was the part of past medical history to his social history and occupational history. So any input, Dr. David?
Thank you very much, Roland. You did a very good job cracking this patient. A lot of details. I like this. So, in the past medical history, just a number of things. I'll try to be quick. So, recurrent admissions. So, it's interesting to know that this is not the first time this patient presents to the hospital. So he had identical respiratory complaints, and so basically about we are talking of 4 and 2 years ago, and he was being treated at the hospital as a case of pneumonia. So my thoughts here are the current presentation, we're hearing that the patient has difficulty in breathing for 2 months. So it seems that probably this is not a very new thing. And of course, when we these are tough decisions that we make sometimes during clinical reasoning, uh, seeing whether the past admissions, whether what we are seeing currently is a continuation of what was seen 4 and 2 years ago, or whether they could be the same issue, but then they are isolated. Like it's not something that is progressive, or maybe they could be completely different complaints, but then involving the respiratory system. So difficult to make that call to say they are completely related or unrelated. But then the thoughts are, if we sometimes we do make errors in diagnosis. Someone comes with difficulty in breathing, and you take a history, and they report it to be of a few days duration, and then you think about you make a diagnosis and you treat the patient. So this is a 56 years old male. Uh, of course, there is something that is complicating issues here: the rheumatoid arthritis and the prednisolone that the patient was given. But otherwise, someone who is 56 years old and they are completely healthy, we do not expect them to be admitted frequently with pneumonias, which raises the question: does this patient have an underlying lung disease? Because if you are not immunosuppressed, if you are healthy, you are either not very young. We pediatricians see a lot of pneumonias in the young, and they're very old because they are old. Every organ system is going downhill, and they have some sort of immunosuppression, and therefore the young and the old can get pneumonias. But then in between, we do not expect to see pneumonias frequently in someone. Of course, even if you see it once or twice, you ask yourself questions: what exactly is going on? So that raises questions in this patient: does the patient have a structural lung disease that is creating a very conducive environment for organisms to grow and cause these what are diagnosed as recurrent pneumonias? Or maybe the patient was being misdiagnosed. But then what makes you consider that yes, they could probably be pneumonias is if the patient was receiving antibiotics and then they get uh, a relief of symptoms. Then you could think that yes, probably uh, the patient could be having a structural lung disease, and then with the superimposed pneumonia, it decompensates things, and this patient becomes very breathless to the extent that they have no choice but to seek medical attention. And when they are given antibiotics, the pneumonia goes away, and although the disease does not disappear completely, but then the patient improves functionally and goes on with their life until they get another round of infection. So that could be one hypothesis. The diagnosis of rheumatoid arthritis. Uh, so if I was seeing this patient, of course, I would try to ask just briefly in order to see the basis for the diagnosis of this rheumatoid arthritis. And of course, when you examine the patient yourself, if it was a late diagnosis, maybe you could see some deformities. But generally, to see if the patient had those characteristics that are in keeping with the rheumatoid arthritis. Because if we have a diagnosis of rheumatoid arthritis, we know that these connective tissue diseases, autoimmune diseases, can come with pulmonary manifestations. So you talk of SLE, rheumatoid arthritis, Sjogren's, systemic sclerosis, inflammatory myopathies like dermatomyositis or polymyositis. They can all come with interstitial lung disease. And therefore, if really there is a diagnosis of rheumatoid arthritis in this patient, then another thing that we have to think about is interstitial lung disease, rheumatoid arthritis associated interstitial lung disease. Another thing that complicates matters is this patient has been on prednisolone since a diagnosis of rheumatoid arthritis. So, as per guidelines, generally what you do is, yes, initially you keep your patient on NSAIDs, prednisolone, these steroids, but then you introduce DMARDs like methotrexate, especially in patients with rheumatoid arthritis. Methotrexate is among the mainstay treatments. So you'd keep the patient on DMARDs and then taper the steroids as much as you can. And if you can keep your patient off steroids, they will remain with the methotrexate, and you achieve remission of the rheumatoid arthritis, then you're in a good place. We do not know the dose of the prednisolone, but we know prednisolone is an immunosuppressant. It causes immunosuppression, and therefore um, a risk of infections like recurrent pneumonias is there. And Of course, it could also be blunting the immune response. So maybe the patient could be presenting with recurrent infections, but you are not seeing fevers and other presentations that are pointing in the direction of an infection. So I think basically it's a number of layers of complexity that are being added here, because rheumatoid arthritis comes in, and what are being diagnosed as recurrent pneumonias, which raise the suspicion of a structural lung disease. And let me see the next slides. So this patient has no other chronic illnesses, hypertension, diabetes. I'm not sure where this gunshot wound was it in the thorax or was it in the abdomen? But then so there you find these, they are not things that we come across frequently, but when you in textbooks, people have people are found with okay, so this was in the leg, not in the thorax. So there could be no relationship completely with that past history. But then this patient has no other chronic illnesses that I was talking about. Uh, the family social history, I think there was nothing significant. But then the social history, So this patient is a smoker, was a smoker, and about 37 pack years. 37 pack years, that is significant. So someone with more than 30 pack years of smoking, they come to you with difficulty in breathing and a chronic cough. A number of things come to mind, including airway diseases like COPD. But then, so COPD common presentation, yes, I mean they might come with uh, there could be wheezing, which we did not see in this patient. And so for the cough, of course, chronic bronchitis. But then with COPDs in general, which is either chronic bronchitis or emphysema, we commonly hear about sputum production, which was not present in this patient. So it's a dry cough. But then I think we also have to entertain that diagnosis. So you can see basically it's more layers of complexity. We have a presentation in keeping with heart failure. Uh, this patient was diagnosed with rheumatoid arthritis. We are hearing recurrent admissions from alleged pneumonias, and then that the patient also has a significant history of smoking. And then an alcohol drinker, of course, you could think of things like aspiration pneumonia, but then it would not play out long term like this. So a number of things here that I'm picking: significant history of smoking, and then the diagnosis of rheumatoid arthritis, the prednisolone that the patient is on, and then the patient has occupational exposures. So uh, if he runs the day-to-day activities of his hardware without using masks, so he's exposed to dust. And when you talk of these airway diseases and lung diseases in general, including interstitial lung disease, outdoor pollution and occupational exposures are part of the major players. So that's another thing that I will keep to mind. So I think it's impossible to commit to a particular diagnosis, because I have not seen any telltale signs of or pathognomonic symptoms of a particular pathology among the ones that I'm considering. Airway disease could be possible, although there are things that are not very much in keeping with it, like the absence of wheezing, which can or cannot be there. But then uh, the absence of sputum production. But airway disease, I think, is a possibility in this patient. Interstitial lung disease associated with rheumatoid arthritis, if we confirm that diagnosis, is a possibility. This patient is a smoker. Of course, we have to think about it. It's important to image this patient. because apart from airway disease, we should also think about other things. So although we are not hearing weight loss, we are not hearing hemoptysis, but then even lung malignancy is something that has to be considered. And then we had heart failure, and that heart failure sounded more of a left-sided heart failure, which complicates things, because if you are thinking of a primary lung disease, whether it's interstitial lung disease or any other disease, and then the patient is presenting with features of right-sided heart failure, you could just discard it and say copulmonale. But then uh, orthopnea, PND, uh, very in keeping with left-sided heart failure, although that demarcation or that distinction is very arbitrary. And another thing that I did not say is, although we consider those symptoms to be specific for heart failure, but they are not 100% specific. We've heard about patients who come with features like COPD, I mean like orthopnea, PND, and then it turns out to be something like pulmonary embolism or another pathology outside the heart. So a number of things that I'm considering. So we'll hear examination, which I do not believe will add a lot, but then when it comes to investigations, I believe I'll make some progress. So let's proceed.
Okay, thank you, David. So let's proceed with our case. So on examination, he was alert, dizzy, cyanotic, febrile. The vitals was he was saturating on 91% on 10 liters of oxygen via non-rebreather mask. But the moment you tend to off him, he desaturates to 82% of oxygen on ambient air. His blood pressures was at 134 over 76 millimeters of mercury. The patient was tachycardic with 105 beats per minute, and was also tachypneic with 34 breaths per minute. The temperature was at 36.6 Celsius. And one thing to add, Dr. David, I also just didn't add his joint examination. He didn't have the swan neck deformities, the bottoniere deformities, and all those joints which you need to examine, especially if a patient you are suspecting to have autoimmune disease. On a respiratory examination, the chest was symmetrically expanding. As I said previously, was tachypneic at rest with visible accessory muscle use. The trachea was midline, and the tactile vocal perimeters was increased bilaterally at the infraaxillar and infrascapular regions. He had dull on percussion. It was noted of both lung bases, and it was resonant to other parts. That means the upper together with the middle zones. The cardiovascular exam, the pulse rate was 105 beats per minute, which was regular, had good volume, non-collapsing, synchronizing with other peripheral pulses, and normal temporal artery pulsation. There was no raised jugular vein pressure, no precordial hyperactivities. The apex beat was at fifth intercostal space along mid-clavicular line with no palpable heaves or thrill. And heart sound 1 and heart sound 2 were ahead with no added sound. And also examination of the liver. There was no enlargement, neither was it tender, and neither was it pulsatile. We did the musculoskeletal was normal. The breast examination I also did was normal, and the rest of other examination was essentially normal.
Yeah, so
So back
yes,
to you, David.
yeah, so some significant findings here, and I think I've already taken a lot of time. I'll try to run. So this patient is desaturating on room air. So when you think of desaturation, and this is a schema that I have to perfect every time, but then yes, patients with airway disease like COPD, yes, we do see patients with COPD who are desaturating. But then, so commonly, it's either when someone is desaturating, it's either a problem with ventilation, gaseous exchange at the air alveolar interface, or a problem with perfusion. So with ventilation, so when the alveoli is filled with water, like in pulmonary edema, for example, or it's filled with pus, like in pneumonia, or filled with blood, like in diffuse alveolar hemorrhage, someone can desaturate. But of course, we also know that interstitial issues, patients with interstitial lung disease, patients with pulmonary fibrosis, for example, can also desaturate. And then perfusion or pulmonary embolism, for example, can also shunt blood and lead to a low oxygen saturation. So these are possibilities in this patient. Now we go to the respiratory system examination proper. So there is I think I need can I see that slide, Roland? Yeah, the patient is tachypnic. So on this one, the patient is desaturating on room air and tachypnic and tachycardic. Let's see the respiratory system examination. A number of things here: a dull percussion note, and then increase the tactile vocal fremmeters. So yeah, I think there are some other things that I would need to conclude, but if I just pair these two together, they point me in the direction of consolidation. So when you have a dull percussion note, because if it's air that is filling there, for example, uh, the percussion note will be resonant rather than a dull percussion note, unless the air is outside, that is in the pleural, like in pneumothorax, then it will be a dull percussion note. But here, if it's inside the lungs, increase there will cause a hyperresonant percussion note, basically. So tactile vocal fremmeters being increased, and then a dull percussion note that speaks of consolidation. So I think a few other findings would help me corroborate that, but I'll just take it that way, that there is probable consolidation here. But so the cardiovascular system examination, absence of some of those findings like a loud P2, which would point us in the direction of pulmonary hypertension. But again, of course, we cannot say that it's 100% sensitive. And so in examining this patient, an echo is mandatory, and it can help us know if this patient has features of pulmonary hypertension. Otherwise, apart from the tachycardia, which I think I discussed initially, I do not see anything else. So other systems are remarkable. So let's go to the investigations, because I think I've taken a lot of time in discussing.
Okay, thank you, David. So we did a full bad picture, and these were the findings. I hope you can appreciate them, David, right? I do not want to go through reading them, but I'll just be projecting. So if your eyes can be able to pick findings, you can note them out. So this was the complete bad count. These were the inflammatory markers which were actually raised, the ESR and CRP. We also did serology screening, HIV 1 and 2, hepatitis B and C were all negative. The serum glucose tests were all normal. The renal function test, there was slight elevation on creatinine and BUN, but electrolyte panel, they were at normal level. The ABG, as you can see, there was derangement in pH, derangement in carbon dioxide, and derangement in oxygen, together with bicarbonate. And autoimmune antibody panel, the rheumatoid factor was positive. Anti-CCP and ANA by either IFA or pattern or titer, they were speckled, and they were at 1:320. And this was the chest X-ray. We also, I was able also to perform the 6-minute walk test, where the patient was desaturating at 78% of oxygen when he walks at a distance approximately 100, less than 100 meters. So these were the investigation done. And also let me include this part here. Any other investigation that you can suggest, Dr. David, you also come to add over there. And so let me take you back here so that you can have a brief discussion before you commit to a diagnosis.
Yeah, so I will ignore this a slight elevation in the WBC count, because if this patient up to this point is still on prednisolone, I would just consider that to be the imagination of the WBCs because of the prednisolone. But I will not ignore it completely. We see an elevation in inflammatory markers, so we will make some efforts to see if there is any infection that is playing out in this patient. Otherwise, I see the hemoglobin, for example, is normal because difficult in breathing. Anemia can also exacerbate difficulty in breathing, but this patient's hemoglobin is normal, eosinophil count normal. I think that's also important. So not a lot in the full blood picture. Inflammatory markers elevated, and therefore I have to think what is inflaming this patient. Is it an infection? Is it an autoimmune disease? Or is it a malignancy? Next. Yeah, we can skip this. Nothing remarkable. So the glycated hemoglobin, if we are talking of the American Diabetes Association, we could say pre-diabetes in this patient. But then if you use British guidelines, for example, that is not pre-diabetes with the glycated hemoglobin. But otherwise, the fasting blood glucose, again, uh, not very crazy. So at least this patient has no diabetes. Whether there is pre-diabetes or not, that depends on the guideline that you are using. Uh, so with this picture that we see here, although we did not hear the symptoms, maybe we could say that because we know that rheumatoid arthritis is a very destructive disease. And therefore, if someone is not on treatment for 4 years, it could have destroyed their joints. So let's just say maybe the prednisolone did a good job uh, to keep the inflammation low and prevent the severe joint destruction that comes with rheumatoid arthritis. But then if you tally clinical symptoms, if really the patient presented with a symmetrical polyarthritis involving small joints, and then you do these tests, rheumatoid factor, 80%, uh, more than 80% sensitivity, anti-CCP very specific, and then ANA, a very high titer of ANA. So uh, this one, in the context of joint symptoms that are in keeping with rheumatoid arthritis, that confirms the diagnosis of rheumatoid arthritis. Now, I'm being careful here because we are discussing difficulty in breathing. We did not question the patient at length to know what symptoms they presented with. But then uh, all these investigations here, I think they increase our confidence on rheumatoid arthritis. Can you see the next one? So this chest X-ray, an interstitial pattern. It's an interstitial pattern. You can see it's more of a ground glass opacities. It's not homogeneous. And then the lower and middle zones are more affected than the upper zones, and this is bilateral. But then, if you look carefully, you can also see some buttering appearance there, which someone could say that pulmonary edema cannot be ruled out in this patient. But then pulmonary edema would just expect it. I'm not seeing significant cephalization of the vessels. So it's more of an interstitial pattern in this patient. Yes, pulmonary edema can present this way, but I think in light of the more than 2 month presentation and uh, and the symptoms that the patient presented with in the past, I think this is an interstitial pattern. And then you asked me what other investigations I would order in this patient, because there is a number of things that I'm thinking about that I was not able to rule out completely. I talked about airway disease. I talked about interstitial lung disease, and then I also had a consideration for heart failure because of the symptoms that we had. So I'll do a high resolution CT scan for this patient. I will do spirometry or lung function tests in general, and I also need an echo for this patient. So I'll do those investigations. I think those can help me make progress.
Yes, so thank you, Dr. David, up to this juncture. So unfortunately, to this patient, on the day when I was able to see and crack him, these were the investigations done. So, however, when I recognized that this is just not just like a similar case, we need to have something to confirm what we are thinking. We I ordered high resolution computer tomography and PFT together with echo, ECG, and the rest of the investigation that I didn't present them here. But unfortunately, at the facility where I was, those investigations could not be performed. So we referred this patient to a higher level facility. However, the patient passed away when he was on the way to the national hospital. So up to that juncture, Dr. David, I think you can just commit to the diagnosis, then have a few teaching points to why I presented this case today and what we can learn out of it. Thank you.
Thank you very much, Roland. Yeah, it's an interesting case, and as I said, difficulty in breathing, a common complaint that we see many times, but then uh, things are not always that easy. So I had a number of differentials that I was thinking about. Uh, so because of the history of smoking that this patient had, I was also thinking about airway disease like COPD, but then I expressed my reservations that there are things about COPD, for example, that we did not see in this patient. Sputum production, because if it was predominant chronic bronchitis, for example, the patient has a chronic cough, but sputum production is something that was absent in this patient, especially with the exacerbations. If we consider the admissions due to pneumonias as exacerbations, we expected sputum production, which was not present in this patient, and then the absence of wheezing. But then I think it's unfortunate. But then if we had managed to do spirometry, for example, that would tell us whether we see an obstructive pattern or a restrictive pattern that could help us make some progress. But then something else that I mentioned after hearing the diagnosis of rheumatoid arthritis was interstitial lung disease. And so because of what we saw, especially the chest X-ray that we saw, that is an interstitial pattern, and it's bilateral and it's very extensive. So I think, and in light of the autoimmune markers that were done that are pointing us unequivocally to a diagnosis of rheumatoid arthritis, I think what I'll keep high on the list is interstitial lung disease. But then, of course, if we had an opportunity, it's sad that we could not do that. But then, an echo and other investigations could help. I'm seeing Cheyo is considering a possibility of mixed connective tissue disease. With mixed connective tissue disease, so the way I think about mixed connective tissue disease is you need to have a clinical presentation in keeping with more than, basically it's not more than one, you are talking of more than two, because if it's just two, then that is called an overlap syndrome. So for example, if you have features of rheumatoid arthritis and SLE, that's an overlap. But then if you have rheumatoid arthritis, SLE, and systemic sclerosis, for example, then we take that to be mixed connective tissue disease. So because the joint presentation that we had was just in keeping with rheumatoid arthritis, if we had other symptoms, so for example, a proximal myopathy, and then skin findings in keeping with systemic sclerosis, then we could say mixed connective tissue disease. So I think this is rheumatoid arthritis, and it has presented with interstitial lung disease. But I will do those other investigations in order to make sure that I'm not missing these other things, because again, these things could coexist. Yes, someone could have interstitial lung disease and they could have COPD at the same time. So those are my thoughts. So teach me, Roland.
Okay, so thank you so much, David. So I think I'm having maybe 4 minutes to wind up everything. So after doing several consultations with a consultant at that hospital, we came into agreement. Though we were not having gold standard, we didn't do gold standard investigations, which is PFT and HRCT, due to the clinical presentation of the patient together with the investigation that we were able to do to this patient. We had an agreement that we are dealing with an interstitial lung disease, and at a large percent, the culprit could be the rheumatoid arthritis. But silicosis together with respiratory bronchitis are other things we also kept on entertaining to this patient. Silicosis, the exposure for cement or silica for 20 years to this patient, it was not something that we could ignore. Also, the history of smoking for 37 years, respiratory and bronchiolitis, it was not something that we could ignore to consider to this patient. So interstitial lung disease is characterized by inflammation of alveolar wall resulting in widespread fibrosis and collagen deposits in collagen type 1, type 3, together with type 5. It's a very, very, very broad baobab with more than 200 heterogeneous group of diffuse parenchymal lung disease. The most important message we can get from the epidemiology of interstitial lung disease, due for it being a diagnosis of exclusion, it is associated with late diagnosis. Hence, by the moment you come to diagnose or to entertain the diagnosis of interstitial lung disease, the disease, it has already progressed, making the numbers now being bad. The most lethal or the most fatal among them is the idiopathic pulmonary fibrosis, which affects older adults, and it's more common in smokers. At the moment when now you are thinking of interstitial of idiopathic pulmonary fibrosis, by that time that means you have done a lot of investigation and nothing is turning out to be positive. So I think for this patient, if we could have an opportunity to be seen by a king doctor at the presentation of those respiratory symptoms together with connective tissue disease symptoms, one could have thought, if it's rheumatoid arthritis, what else has it affected? Because this patient had all the modifiable risk factors, the cigarette smoking, the occupational exposure, and all other things. So that was the most important thing on risk factor. There were more than one risk factor to this patient. the smoking habit itself, the exposure that he had on on his work space as a cement seller, but also um, the autoimmune disease, which was also ongoing. So these are some of the few etiologies, and the general pathophysiology, which I will not go through. It ranges from trigger up to matrix remodeling. And one has to think of an interstitial lung disease as a tree, as a baobab tree like this, with a lot of issues, as Dr. Devja has spoke with a lot of details on these issues. However, you should also be able to come and classify either based on American Thoracic Society or European Respiratory Society. To this patient of ours, the number one thing which we entertained, it fell on the connective tissue disease, and the other one, it fell on idiopathic pulmonary, idiopathic interstitial pneumonias, the respiratory bronchiolitis. So was an excerpt from Harrison. If somebody could have appreciated that this patient has had a breathlessness, which was chronic, exceptional, and had dry cough, and on examination there is presence of fine inspiratory crackles, then the interstitial lung disease diagnosis could have been made maybe 4 years ago, And the diagnosis criteria now for interstitial lung disease, it involves multiple disciplinary team. An internist or a pulmonologist should be there, a radiologist for radiological features, description, a pathologist for concerns, especially when handling the handling the histopathology sample. So at the end of the day, interstitial lung disease is going to be being managed either pharmacologically and non-pharmacologically. Non-pharmacologically, we know you do the modifiable risk factors, stop smoking to the patient, adherence to medication. But when we confine to medication, we out of many medications that are given, most two prominent are nintedanib together with pirfenidone, and all these are antiphlobotic and anti-inflammatory drugs, which have the goal to inhibit transformation growth factor signaling. Apart from pharmacological management, oxygen therapy is key important to this patient. Then at the end of the day, since interstitial lung disease has got poor prognosis, patient will end up in palliative support care. So I didn't manage to do the gender, age, pulmonary function test index for this patient to be able to approximate his prognosis, but these are the parameters that we consider. Due to absence of pulmonary function test, it could not be done. And staging, you could have staged 1 to slow progression, rapid progression, or acute exacerbation. However, prognosis to patient with interstitial lung disease is poor. And the only reason that I've stated is that people are usually misdiagnosed early. So patient is being treated, for example, our case was believing to be having pneumonia, but however, this pneumonia, it was refractory to management. Follow-up is also very important to patients. And why now did I present this case? I think if we could have a chance to see this patient 4 years ago, we could have a diagnosis of interstitial lung disease area, and the management maybe could have set area, because at that moment maybe one did not think of interstitial lung disease. It just focused of rheumatoid arthritis, and that's it, without knowing that rheumatoid arthritis doesn't only confer to joints, but also other organs such as the the kidneys, and the lungs and the heart. They can all be affected. So, Dr. David, though I had a bad day on that day due to death of this patient, I saw that it was an important case for us to learn. So thank you for the time and chance that you have given me for this Sunday to present this case. So it's time for you for reflection, and then we can call it a day, sir.
Roland, thank you very much. So first of all, I think we can all agree that you did a very good job clerking this patient. The clerkship itself was on point, very detailed, and of course, making a diagnosis that the patient has been going round and round for 4 years and without a diagnosis or being treated for other issues, and the main issue being ignored. And I agree with you that probably, although we know that these diseases are very progressive and aggressive, but then probably if a diagnosis was made earlier, maybe something could have been done to at least slow the progression, and maybe we could still be having the patient with us. So thank you very much, because this was a, a very intensive learning exercise for me too, because it's difficult in breathing that we see many times, but then it humbles me that yes, could be the difficulty in breathing that we discuss over and over, but there are many layers of complexity, and therefore keeping a broad differential is always helpful in order to make sure that you do not miss anything. So thank you very much, Roland. This was very good learning for us, and I would like to take this opportunity again to remind others that Roland is showing us the way. Roland saw a patient, someone, because there are some other doctors here who I believe have seen ILD patients who have been misdiagnosed many times, and maybe they were given anti-TBs twice, thrice, without improvement, but then they said, oh, it's just interstitial lung disease. I think there's nothing really special about this patient. But you can see that we had a lot to learn from this case, and which led me to discuss for a long time up to this time. We are beyond time, so please, we remind you again that you are seeing very interesting cases, and we can learn a lot from those cases, remembering that we are learners of different levels here. There are medical students, there are registrars, interns, specialists, and others. So a case that you bring will teach someone something, and that will have a positive impact on a patient somewhere, leading to a right diagnosis, which is timely, and that patient gets the right treatment and is saved. So again, thank you very much, Roland. We are beyond time, but if there is someone with anything quick, anything burning, please, you can just unmute and maybe spend a minute or two before we close.
Okay, I wanted to add something.
Yes, Nebo, welcome.
Roland, thank you so much. Very good presentation. It was very excellent. The message that I want to add is that as clinicians, we should not forget to screen this patient for interstitial lung disease, especially if the patient has rheumatoid arthritis and is on treatment. So the recommendation is that at least once per year, if the patient is stable, a HRCT must be done. Because sometimes you may find that the patient has been treated for more than 3 years and comes with acute symptoms of difficulty in breathing with a pattern which is purely an ILD. So yearly screening of this patient, but also at least if the patient is presenting with symptoms, a follow-up of maybe 3 to 6 months as per recommendation of the European Respiratory Society guidelines. So it's very, very important to screen this patient. But also, as Dr. David said, even if the patient is on methotrexate, it should be noted that it can also be a compounding factor because rheumatoid arthritis by itself, 50% of patients with rheumatoid arthritis might end up with interstitial lung disease. So if the patient is on methotrexate, again, it's a compounding effect. So screening this patient is the message that I want us to take here.
Thank you very much, Nebo. That's very good teaching points from you. Thank you very much. I do not see any other hands or anyone who was unmuted to speak. So if there is nothing else, thank you very much, everyone, for joining. Thank you, Roland, for presenting. We hope to hear from you soon again. So have a good night, everyone, and see you next Sunday.